Now I want to introduce Dr. McCarris. We're so excited that you've taken the time to do this for us, and I just wanted to give a little background on you. Dr. McCarris, as a developer of his own surgical technique, the McCarris technique for MIS hysterectomy, is a recognized authority on minimally invasive procedures and the founder of the McCarris Surgical Specialist for Women. A lecturer and a preceptor in high demand, he's traveled to China, South Africa, Australia, Singapore, and throughout the U.S. at the request of institutions like ours who wish to benefit from your live presentation. So thank you. Dr. McCarris is currently the chief of the Division of Gynecologic Surgery at Celebration and Winter Park Hospitals. His research resume includes dozens of published articles on advanced techniques, and he has also spearheaded a pioneering MIS fellowship program. So without further ado, I'd like to get on with the understanding the impact of complex chronic diseases and hypertension, and pass the gavel over to you, Dr. McCarris. If you are able if you're not able to move the slides, just let me know, and I'll be happy to help. And I'm going to hide my screen. And welcome.
Okay, Jenny, can you hear me okay?
I can hear you perfectly.
Well, I want to thank you so much for inviting me to be part of this great Women's Health Summit today. I've tuned in the beginning of the summit and have thoroughly enjoyed the several conversations by many of the speakers today, and I found it very enlightening to listen to the last presentations on mental well-being, and also thoroughly enjoyed the last 10 minutes. It's probably the best 10 minutes I've had in a couple of weeks, so thank you for that. It is my pleasure to be with you today, and I hope I can enlighten you about just one aspect of women's health that really can involve many of the comments and the issues already brought up today. I think all of us are aware of the diseases like hypertension and diabetes. There's been much conversation and information throughout all our lives about hypertension and diabetes, but really I want to bring another issue into the conversation that can impact those diseases without really understanding or even thinking about this issue known as endometriosis. Let me see if you can take the next one, Jenny. Is there a way that I can advance, or?
You can advance them. That you should have the ball right now, so you should be able to advance them, no problem. If you do have a problem, just say, Jenny, advance, and I will be happy to do it.
Okay. Is that the first slide?
It is the first slide.
Okay. Okay, so what I wanted you to know about endometriosis, that this is a disease that affects a tremendous amount of reproductive age women, and reproductive age is really defined from the age 18 to 49. About 10% of women in this age group, it's estimated, are dealing with this disease of endometriosis, and it's a tricky disease. It's a disease that is related to the menstrual cycle. And many of you are familiar with the fact that during the reproductive age in a woman's life, she menstruates every month. And that's a discharge of uterine tissue from the uterus to the outside of the patient's body. But in a tremendous amount of patients that have normal reproductive organs, that tissue, called the endometrium, can leave the body, but also in a retrograde fashion, going back through the uterus, through the fallopian tubes, go inside the pelvic cavity, and can actually start menstruating every month just as the uterine tissue does. And that really is a disturbing disease that can affect the patient. And it seems like a lot of patients will take that as a normal event, that they're unlikely to talk about it or want to elaborate on the fact that they're having painful periods or pain with intercourse or even pain when they're not menstruating. And endometriosis is an enigma. It's a disease that's been around for centuries. There's no pathognomonic way to diagnose the disease. And a lot of patients are plagued with this disease and aren't seeing proper physicians or treatments or healthcare providers giving treatment. And it's noted that about 40% of women with endometriosis can progress to become infertile, and infertility, the inability to conceive. So it is a chronic problem that creates havoc in the prime of a lot of women's lives in this age group that really they're very productive and busy doing many things that they're trying to accomplish. And Jenny, let's see, you can go to the next slide. The disease itself can affect not only the patient, but people around her. And many of you may have a sister or a daughter or a mother or aunt or a family member, somebody at work who really has endometriosis. And it affects not only them individually, but you around them, trying to understand what is wrong today. Why aren't we having a good day today? And it affects not only the patient, but also in the workplace. It seems to be an issue that isn't talked about much, and hopefully after today's summit, we can bring it to a new level and really a call to action on what it's doing to patients and people in the workplace and also people around her. Okay, Jenny. The treatment has also been very haphazard. This slide shows many of the pharmacological treatments once endometriosis is diagnosed. And most of these treatments, like Advil or Motrin, will help pain with menstruation, but really not treating the disease. And dysmenorrhea is the name that's given to pain with menstruation. And dysmenorrhea is a symptom, and I see patients on a regular basis in my office that complain of painful menstruation, and oral contraceptives are the treatment, the first line treatment for that symptom. And about 50% of the patients that I put on birth control pills, and usually we start them on a low dose pill for 90 days or 3 months with a pain diary, about half of the patients will get better. And that means 50% of the patients don't get better. So we try other medications, like an intrauterine device that releases progesterone, or another progestin called depot injection of progestin, a monthly injection. Or sometimes we'll use medications that really shut down the ovaries, because endometriosis is an estrogen-dependent disease. And we talked about the fact that it usually presents in reproductive age women who are 18 to 50, but you never see endometriosis in a 10-year-old patient, or you never see it in a 70-year-old patient. So it really is an estrogen-dependent disease. So one of the FDA-approved treatments is a medicine called GnRH agonist, and that's really helped many of my patients over the years. And there's also this issue around patients having significant moderate to severe pain requiring opioids like Percocets or Percodans or Narcan to really take their pain away. And so the medical therapies have really been not very helpful over the years, and I'm happy to tell you that we do have some new exciting medications that have just been FDA approved that seem to work very well, at least in this early launch of having that drug available. It's called a GnRH antagonist, and I've been fortunate enough to learn about this medication and helped about 40 patients so far with a new medication. And then medical therapy is complementary to the surgical treatment of endometriosis. Endometriosis is a very inflammatory, proliferative disease that causes inflammation with nerves that grow into the disease and blood vessels that grow into the disease. And the disease can be anywhere in the pelvic cavity or even outside of the pelvic cavity. And it really is a very tricky, aggressive disease. So surgery has also been a treatment where we can take what's called a laparoscope or a laparoscopy and go through a very small incision through the umbilicus to visualize the disease and try then to treat it surgically. And also patients have undergone larger incisions called laparotomies to remove an ovarian cyst or an ovary, or even adhesions associated with this inflammatory condition. So it's a surgically treated disease. Some patients even have to undergo a hysterectomy, which is removal of the uterus and the cervix and the tubes and ovaries. So this disease really has had a lot of different surgical and pharmacological approaches. And one of the things I've personally been working on over the past year and a half is a care pathway, a standardized methodology so it can be more streamlined in the approach, holding surgery as the last treatment option and looking at some of the more earlier available medical therapies. And that's something that is very, very important to understand and to get healthcare providers educated about what's new and available so patients can get treated quicker and have better outcomes. And that's really important, I think, in the employment industry and companies helping educate patients about some of these newer treatments and understanding what these options are so they can really ask questions to their physicians and their healthcare providers about these certain options. Okay, Jenny, we'll go to the next slide. So if you really look at what patients are trying to accomplish and the impact this disease has on employers and employees throughout the health workplace, that most patients with this disease have searched and searched to try to get help. And the patient really just feels better. And you look at a lot of the surveys that have come out over the past few years, this one looks at medical treatments over a patient's reproductive lifetime trying to feel better. And 45% of the patients in the survey responded that they had 3 or more medical therapies. And it was amazing how some patients had almost a dozen, using birth control pills and a different pill, a cyclic pill or a continuous pill, or a progestin therapy. And it just seems like this extension of care is not really solving the problem, making the quality of the life of the patient better, quicker. And then if you look at surgery, it's not uncommon to see an endometriosis patient that's had multiple surgical procedures. 41% of the patients in this survey reported 3 or more surgeries, where some patients had a dozen surgeries or 5 or 6 surgeries. And laparoscopy really has been the mainstay. And laparoscopy is a surgical intervention which is really dependent on the surgeon, what the surgeon's experience is, and how the surgeon would treat the disease, whether they would just look in the abdomen and take a picture, or use energy to ablate or to burn out the disease, or excise the disease. So surgery is really purely dependent on the surgeon. And how does the patient know the experience of the surgeon? Medical therapy is kind of universal. If you take 1,000 surgeons doing surgery and they all use medical therapy, then the outcome should be the same and not dependent on the surgeon. So we have to kind of think about what's best for the patient, and she needs to know what the appropriate options are. And honestly, most of the patients are just depending on the healthcare provider to tell them what they need to do. And I think that is really wrong in today's age of education and information and what we know about this disease. So it really takes all of us. It was like the panel that was preceding me talking about, you have to be able to talk about it and open up about it and ask questions about it and vet your surgeon or your healthcare provider. And it really takes all of us to make this happen and to move the needle to get us into that comfort zone about this disease and what the best treatments are, because you can tell it's very confusing and all over the board on what women go through. Okay, Jenny. So 70% of the patients with endometriosis are unable to relieve their pain. And it speaks directly to all the different treatment options, that there aren't FDA-approved treatments in a lot of these medical therapies. And if you look at using medications, it's really been amazing that the information has been showing that opioids and painkillers are being used more commonly in patients with endometriosis. And we all know the issue about opioid problems that we have in the country. And remember, surgery has been shown to be a gateway to opioid treatment, use, misuse, and abuse. The information is pretty compelling that women that have endometriosis are more likely to have surgeries. And if there's more likely to have surgeries because of the disease, the use of opioids and the use of other pain medications is much higher in patients who don't have surgery. So the issue around surgery is really multifactorial, that it's risky, there's complications, it's surgeon dependent, it's costly, and it really doesn't show long-term improvement of pain, that patients with endometriosis really end up with multiple operations. So we have to kind of look at a better way, and maybe it's really patient awareness, early recognition of the signs of the disease, and starting medical therapies earlier. We talked about hypertension and diabetes being a chronic condition. It's really time for us to understand that endometriosis, which has a high prevalence and incidence in reproductive age women, we need to look at this disease as a chronic condition. It's terrible to have to get to the end of a treatment and basically remove the ovaries and remove the uterus because of a condition that's played havoc on a patient for 20 or 30 years of her, prime time years of her life. So it really is important for us to relook at this disease and understand it and educate women about it early on in this journey, and not late after multiple operations and multiple medications have been utilized to try to improve pain that the patient is having. Next slide, please. You also want to look at the aspects of this disease beyond a hospital setting, beyond the monthly menstruation that creates a lot of pain with bleeding or pain with intercourse. Endometriosis has been known to really have three major symptoms: dysmenorrhea, which is painful menstruation, and we're really talking about moderate to severe pain. Not mild pain, but severe pain that keeps the patient from being able to do what she wants to do. And then pain with intercourse, dyspareunia, painful intercourse is an issue. And also chronic pelvic pain, where it's not just with menstruation, but there's pain throughout the month at different times. In this particular slide, it does show how this disease, endometriosis, looking at patients in a large cross-sectional study collecting data, 50% of women said this disease, endometriosis, and its symptoms that are occurring affected their work, the ability to function at work, or even go to work or be productive at work. Another 50% in the survey showed it's affecting her relationship, whether it be sexual or physical activity like exercise, or taking care of herself or her family, her children, and doing things she likes to do, like going to yoga or playing sports or doing other type of hobbies. And then about 16% in the younger age in this study, this outcome study, said it affects her ability to focus and to accomplish an educational goal. So you can see where this disease is not just related to infertility. We said about 38% of women with endometriosis then become infertile, and you can understand all the repercussions of that part of her life, not being able to conceive, and all the in vitro fertilization, reproductive assisted technologies that come in from a stress point and financial point. but this affects her ability to focus at work. And what's that do to the workplace and her ability to have sex or to have a relationship with a significant other and do activities? So it really is a disease that's way beyond what we've considered to be in the past. It really affects a lot of her activities in a lot of different areas of her life. Okay, Jenny, we can move. Next slide. And then if you think about how endometriosis affects the ability for her to exercise, her ability to eat healthy, her ability to function and achieve goals, and then her ability to really nutritionally be stable, you can see where over time there's a real correlation with more serious diseases. Endometriosis is an inflammatory disease. It's a dysfunctional immune system that really can't clear that endometrium that falls into the pelvic cavity. And the immune system is really dysfunctional. And it occurs in about 10% of reproductive age women. So if you look at somebody who's 18 years old or 22 years old who has a life journey of endometriosis, it's not so surprising to see other comorbidities that occur with this patient. And you see some of those listed here, that there's an association with endometriosis with other diseases like ulcerative colitis, an inflammatory bowel disease like Crohn's disease, or skin changes or other bone issues from the immune system. There's also a relationship with bad eating or weight gain because you're in pain or you're taking medications that affect your ability to exercise, like opioids or nonsteroidals, and then you get high cholesterol or high triglycerides and hypertension. So you see that the spin-offs are really as devastating or more than the disease early on. Also, there's a relationship with ovarian cancer and breast cancer. And then, you had an incredible panel on the mindfulness in the workplace by all the speakers, and I couldn't help but think of endometriosis and mental health conditions. So it's much more than we even know what's causing depression or the ability to concentrate or anxiety. Could be because the patient is having pain 3 weeks out of the month and has to seek help and can't seem to find it. So this is a huge issue that has multiple legs and is growing deep and wide, that we really have to come back and focus on how we can be more effective early on to prevent some of these later on sequelae and comorbidities. Next slide, please. There also is the issue of cost associated with endometriosis. It is a big burden. If you look at all the emergency room visits, all the doctor visits, all the laboratory tests, the sonograms, the CAT scans, the MRIs, the days missing from school or from work. So there's direct costs associated with treatments, multiple surgeries, evaluations, all the hospital visits, and then the indirect costs from not being able to go to work because of having surgeries and missing work because of having severe, moderate pain. Somebody needing to miss work to take care of the patient, all the things that you can imagine. The societal burden of this disease back in 2008 was reported to be $69 billion. And this is just one problem in women's health that we actually have not done a good job in really diagnosing and treating. And we really have to, I think, bring this to light and make it more of a conversation and education to really change this. We have a great opportunity to be better healthcare providers and all of us working together to really focus on patients that might have this disease. Next slide, please. And then if you look, and I was here, I'm in Orlando, Florida. I work at two community-based hospitals, Celebration Health and Winter Park Hospital. And a year and a half ago, I actually did a data pool on women who went to the emergency department with abdominal pelvic pain. And you'll be amazed that patients with endometriosis, really the utilization of healthcare is much higher than patients without endometriosis, with more hospitalizations, emergency room visits, and outpatient visits. We were really shocked to find at our institution the amount of patients that would come into the emergency department with abdominal pelvic pain that would be admitted for observation. They'd get an IV started with fluids dripping. They'd get all the patients would be admitted with an abdominal pelvic CAT scan, and then they would get IV Dilaudid. They'd give them 1 or 2 milligrams of IV Dilaudid, order a CAT scan, put them in for observation. They'd be in the hospital for 4 to 6 hours just being observed, and you can imagine what happened. The CAT scans came back negative or normal. The patient's symptoms greatly improved because IV Dilaudid really makes you feel better, and the patient would be discharged. And there was really no follow-up. And the patient was told to, follow up with her primary care doctor, her gynecologist, and that was it. And the quality of care was really devastating. So we really built out some care pathways so we could be better at diagnosing and following up and trying to cut down this burden of healthcare costs without really good care. The numbers really speak for themselves. And think about all the employees in your company that go through this, that have this actually occur to them. And how can we help that patient feel better, not only physically, but mentally, and being able to get to work and do a better job and not be plagued with the possibility of surgery and medication abuse. Okay, Jenny, next slide. And also we look at the share of costs with patients with endometriosis. The data is really surfacing in these cohort studies. These were thousands of patients with endometriosis with increased comorbidities and other issues related to the disease. And the share of cost in this particular healthcare problem for women was really amazing, that patients with endometriosis have an increase in healthcare spending versus patients without endometriosis, and all the other issues that come into play, whether it be an inflammatory disease or infertility or pelvic pain, ovarian cyst, or even the association with ovarian and breast cancers. It really is a significant increase in healthcare costs. So I believe that if we start early on with quicker, better diagnosis and medical therapies, that overall health of the patient is really going to cut down on some of these healthcare costs as she gets older and stays healthy and can temporize the disease and not letting it progress, because endometriosis really is a progressive disease. It starts out as a stage 1 or early stage and progresses into an anatomically distorted pelvis with ovarian problems and adhesions and bowel and all those types of things, and an immune system that really is dysfunctional. So we know that the healthcare costs are mind-boggling, that we really can't ignore this anymore, and we really have to key in on how we can do a better job and help patients get diagnosed and treated earlier on in this journey. Okay, Jenny. So the direct healthcare cost on endometriosis in your organization, have you measured it? Have you done any call outs to endometriosis or dysmenorrhea or dyspareunia or pelvic pain? What's in place at your institution so we can educate patients about this disease and not keep silent any longer, that it's not normal to have severe or moderate pain with menstruation or pain with intercourse, and how can we help you understand this? And it really is important to try to answer this question. So we'll go to the next slide. We also look, and the endometriosis really affects performance in the workplace, and I think that really would hopefully stimulate you if you don't have an awareness campaign or any principles or policies in place to educate women about this disease. it really would be helpful, I think, to consider it. Because if you look at the lost productivity, it's amazing. It's amazing when you think about, I mean, I'm a OBGYN, I have 12 people working in my office, and if one person's out for 2 or 3 days every month, that affects the overall production of my office. And I'm one of 400 doctors that work for Advent Health. And if we look at this across the system, it really starts to add up. And this was some information that came out on some outcome surveys that over 900 patients on a questionnaire reported to have a reduction of the number of hours per week by 48% just due to pain associated with endometriosis. And then looking at patients that either went to work or what's called presenteeism, where they don't want to miss work, but their productivity really was down because of feeling bad, or absenteeism, it averaged out to about 8 hours a week. That's 1 day a week where there's a loss of productivity in the workplace due to a disease that actually could be managed medically and surgically in the right hands very effectively to get this patient to where she's not missing work and multiple hours and productivity. So it really is substantial and something that deserves a conversation and an evaluation to see what is going on in the workplace here, and how can we improve it and help these patients, number one, but also have a reduction in productivity and increase productivity and the quality of work that's being done each day or each week. Jenny, we'll go to the next slide. There's mild, moderate, severe, and moderate and severe pain is significant. That's pain that requires either medication, whether it be a non-steroidal anti-inflammatory or an opioid type of medication. If you look at patients with severe pain, the loss of productivity is substantial, and this was reported on hours per week, and they with severe pain, and this is pain where you really can't even go to work. You don't want to get out of bed, you're curled up, it's significant, you really feel bad, and you really either can't go to work or you go to work and you kind of just push through it, and you lose about 16 hours per week of either absenteeism or presenteeism, with severe pain being substantial. And of course, moderate is less than that, about 10 hours a week, and mild pain is about 2 hours a week. Well, if we had some type of treatment, whether it be medical, surgical, or both, to decrease moderate to severe pain associated with endometriosis, we would think that it would improve this information, that patients wouldn't have to miss work. And I'm happy to tell you that there is a FDA approved, it was approved in July of last year, a GnRH antagonist. It's an oral agent. It's called elagolix. It's an oral agent that I've incorporated into my practice for moderate to severe pain. It's 1 pill a day or 1 pill twice a day, and in over 50 to 70% of patients in the original trial, there was a statistically significant reduction of pain. Well, that's something that I think is wonderful for women and wonderful for women's health, and actually something that I'm really glad that I can add to my armamentarium to try to get this pain under control so the patient can do her job or do her hobbies or do whatever she wants to do and at least feel better without using an opioid. So it's really exciting that we have a new medication. I hope that you all know about it or will learn about it and make sure patients know about it, because I think it is something, as we know, a lot of times patients have to educate the physician on what may be an option for them, and I never think that's a bad thing. I think that's a good thing, and I'm certainly open for anyone who comes in and wants me to investigate a treatment for them. But I think this slide really says it all, that we have to do a better job in reducing the amount of pain this disease is causing women every month or even every day. That we really have to have a call to action and be better as healthcare providers. Okay, Jenny, we'll advance it. And if you look at this, it's not only the patient's responsibility to learn about these medications, but it's also the physician. I hate to tell you that there's no two surgeons alike. I've trained thousands of surgeons in my career, and I've never met two that operate the same. So surgery, I think, is not the answer. It's really keying in on healthcare providers that understand the disease and making sure members understand that not all physicians are going to really be pros at endometriosis. As a matter of fact, it's not uncommon for a patient to see multiple physicians. In one of the surveys, it was really amazing to me that 63% of patients said that one or more physicians told them that nothing was wrong, that having pain with menstruation can be a normal thing. Well, I would argue that it's not normal, and there's certain things that we can do to try to alleviate that. So you really have to make sure you vet your physician and not really be satisfied with saying that everything's okay and it takes multiple doctors to diagnose this problem, and making sure that patients understand that you have to really seek someone that'll listen and understand that this is a problem that we have new treatments for, and we want to try to make you feel better. And that's really important for patients to understand, that it's not normal to have severe pain or moderate pain with your menstruation, or to pain with intercourse, or have pain throughout the month and not know what's causing it. Okay? So this is a journey we want to eliminate, and I think it is important for employers they have an obligation to help educate and support a patient with endometriosis, and to be able to talk to her about it and let her open up and understand that there is help, that we don't want you to have multiple operations or have multiple medications that are Band-Aids hiding a bigger problem, or getting, there was a recent trial that showed patients with moderate to severe pain, 18% of the women were using opioids to treat their pain. But we have to do better than that this journey can be an arduous one, from age 16 to 18 with severe menstruation, going to a family doctor who maybe gives you some Motrin or Advil. Then finally at age 18, going to the gynecologist who says, well, let's try birth control pills, and you spend 2 or 3 years on different types of birth control pills, and then you're 23 in college and still having a hard time. You end up having a surgery, and then another surgery, and yet a third surgery, until finally somebody is astute enough to recognize that this is a disease that's chronic. There's really no cure, but there's definitely good medications and appropriate surgeries that can improve quality of life. And improving quality of life so you can be productive and really do well at your job, and really thinking about how we as employers can be better. I think this is a step that may be helpful. You can advance to that next slide. That's perfect. So what can we do? This says talk to your benefit partners about the right plan design for your members. You need access to appropriate care. We need to educate women about going and having an exam. Another survey said it took a patient 4.5 years before she even got to a healthcare provider. And then once she got to the provider, it took another 4.5 years to get to the correct provider. So it took a decade. And we really want to shorten that. That's just way too long and inappropriate with what we know about the disease. So educating members to have annual exams, to talk about if they're having painful menstruation or pain with intercourse, to make sure the healthcare providers are getting access to be able to do an ultrasound or do a good exam, order some blood tests if needed, rule out other problems. If surgery's needed, an appropriate surgery, and then really getting access to the right medications to help manage endometriosis, to suppress it. Remember, it's an estrogen-dependent disease. So we really want to modulate or reduce the amount of estrogen to keep the disease suppressed and keep pain down, to keep the symptoms down. There's actually some new medications. Orilissa or elagolix is a medication that is new that does that. And then making patients understand that this is a chronic disease. We have to stay under good therapies with support and education and guidance to prevent infertility. So we really have to open up the lines of communication in the workplace, have helplines and nurse practitioners and nurses that'll talk to patients and have the correct providers. That's really a first step that maybe many of you are already doing. I hope you are. If you're not, we're more than happy to help you in any way we can. Then the next slide really talks about provide your members with educational materials, to raise awareness about the disease. How is it diagnosed? How is it managed? What are your options? Here's a website that is available for great educational materials about endometriosis. It's Speak Endo, endometriosis, speakendo.com. I hope that you'll guide patients to that website to learn about this disease before they see a healthcare provider. I think that would be a huge help. Okay, Jenny. And then I think it is important to understand that maybe an employee's performance is something that's affecting her that hasn't been talked about, that she is not willing to open up readily about such a personal thing, that endometriosis is a debilitating disease without any pathognomonic signs. And endometriosis is chronic. And it really is important for us to make sure we educate all of ourselves, from the hospital side to the provider side to the pharmacy side to the surgery side to the employee side, that this disease really is so common in reproductive age women that it really needs to be investigated, diagnosed, and effectively treated to improve really the quality of life of that patient. Her workplace will be much better. Her social environment will improve greatly, and her personal life will definitely improve if we can get this disease treated and get the pain managed. Let's see, next slide. I think that's the last slide. Okay, good. So hopefully I've been able just to stimulate your thought about this disease. It's a lot to cover in a short amount of time, and there's a lot of information. You can Google just about anything there is about this disease. Something will come up. You can come to my website. I have macarisgyn.com. I have a lot of information on my website about endometriosis, and hopefully we can answer any questions that you might have.
Well, Dr. Macaris, thank you so much. This has been really enlightening, and I don't think it's an issue that we really talk about very often, and certainly not something that, as a group we, discuss publicly. And I think it's so important, and I'm so thankful that you took the time to speak to our audience to talk about the repercussions of not addressing it. And there are a couple of questions. One person wanted to know from you, can endometriosis be resolved by removing only one fallopian tube and or one ovary and not both fallopian tubes or both ovaries?
Yeah, and you have to remember this disease is estrogen dependent. So if the patient's making a certain amount of estrogen, it can stimulate the disease. The endometriosis actually stimulates the production of estrogen. So we try to minimize any estrogen for it to feed off of. So taking one ovary out, it just depends on the patient's history and situation. There have been times where, for example, I'll remove the uterus and one ovary and leave an ovary to see how the patient does, because you hate taking out both ovaries on a patient, especially, let's say, if the patient's 40 years old. And her ovaries, you go into the average age of menopause is 51. And taking out both ovaries affects her entire body, her hair, her skin, her bones, her heart, her bowel. So estrogen is so important for women's health. So the answer is yes, you can leave an ovary, but the issue is you have to monitor the patient carefully and see there could be a problem down the road. But a lot of times when I have that discussion with the patient, she's willing to take the risk by leaving an ovary than at age 40 taking out both her ovaries. So you individualize the care to each patient.
Got it.
See
And
what she
what would you tell employers who are looking for more materials on education or wanting to advise women that come to say their benefits partner and say, I have this issue? How do they find a physician like you, or do you have people that travel to you? How do they find physicians that really specialize in?
Well, Jenny, I think, there are ways to find doctors. There's endometriosis associations, AbbVie. AbbVie is well aware of who endometriosis physicians are. You can Google endometriosis and physicians will come up. But a lot of times that information, I think your organization needs to do it. I really think your organization, because you're into health and wellness, right, that you could provide a lot of your customers, if I can use that word, healthcare information and get them educated internally to provide that to their members. I mean, we can definitely do that because really there isn't one organization that knows who the best endometriosis physicians in the country are. Maybe that's something we should develop.
Sure. I mean, we're doing industry pulse surveys, and I think that's one certainly that we could discuss is pulling an industry pulse on best surgeons and best outcomes and practices for endometriosis and other diseases, and I think that's a great suggestion. Your presentation was phenomenal and definitely shed some light on something that I don't think is talked about enough, and so we really appreciate your time. And thank you for answering the questions that we have. And we know you are a practicing physician running a big practice, so you gave us a lot of your time, and we really can't thank you enough. So thank you.
It was my pleasure. I hope it helped. Thanks a lot.